Good evening, dear colleagues and doctors. It's a pleasure to present our second webinar meeting under the umbrella of the Saudi Society of Men's Health in collaboration with Tabuk Pharmaceutical. And this time we are doing it in cooperation with the Middle East Society of Sexual Medicine, as presented by its president, Dr. Talal Murdad. My name is Dr. Qutayb Al-Mitwali. I am consultant urologist and andrologist and vice president of the Saudi Society of Men's Health. Gives me a pleasure to present Professor Arthur Burnett, who is a professor of urology at Johns Hopkins University Medical School. He is also director of the Male Consultation Clinic at the James Buchanan Brady Urological Institute. Professor Burnett is an authority in andrology and andrological surgery, and he has a large number of publications in this field. Professor Burnett, please.
Well, thank you very much, Dr. Mitwali. Certainly an honor and a delight to be able to present for you and be part of this webinar. Certainly very topical subject matter. And my presentation is how to manage sexual life during the COVID-19 crisis, with a focus on clinical practice and policy perspectives. So let me load the slides here. My objectives are to review the possible impact of COVID-19 on sexual function and relationships, and I'm going to focus really on the matters of the viral effects on sexual function. Dr. Mona Rita will speak more on the relationships side of that aspect of the discussion. I will also address the impact of COVID-19 on sexual medicine practices, with concerns of how do we as healthcare practitioners take care of our patients, and what sort of guidelines and considerations should we have in light of this pandemic. And then finally, I would like to present on the rational interventions to preserve sexual health in a global health crisis. And this is to speak to the perspectives of, in a more global view, considering how we should deal with this viral pandemic. I'm going to speak a bit with concern of a previous pandemic with HIV and lessons we have learned from that as to how we may be able to proceed with this new pandemic. Now, this subject matter speaks to the science of social ecology, of infectious diseases, and how is it that we have in the human condition now have the origination of viral pandemics. And this may have to do with the way that we have developed our microenvironments with conditions that favor the development and spread of microorganisms. Factors of disease spread by humans include a host of factors, including the way that we go about our lifestyles of living conditions that can be unsanitary, malnutrition, societal changes, and how we address both sexual mores as well as various recreational activities. This may all have to do with how we have evolved to have these viral pandemics. Now, the implication is that we now are dealing with a public health threat that perhaps we did not accept would likely be a problem, as we have made improvements with regard to dealing with infectious conditions, and we have predicted that chronic health conditions would be more likely problematic for us. But in point of fact, we still are dealing with infectious and contagious diseases. Now, the resurgence of infectious diseases are listed on this slide. Certainly, we had dealt with a century ago some of the major ones that we know had a huge societal impact, from smallpox to tuberculosis to even the Spanish flu that we dealt with about 100 years ago. Nonetheless, here we are in modern times dealing with very significant infectious diseases, and the more recent one now, of course, is coronavirus 2. Just to briefly talk about it, it is termed severe acute respiratory syndrome, coronavirus 2, SARS-CoV-2, and it has similarities to the Middle East respiratory syndrome in terms of respiratory symptoms being a predominant clinical presentation. Transmission is believed to be human to human, which is important to understand how the disease has spread. It is not from animals to humans. It is now human to human contact. And I will also talk in a moment here about how that transmission may occur in the field of sexual medicine. Our response strategy at this time, because we do not have an antiviral treatment, has standardly been isolation, quarantine, social distancing, and community containment. And this is the basic public health practices that have been largely used globally at this time. Now, in terms of impact, there have been some perspective literature in the field. One here from Riley and his colleagues had the perspective that this pandemic on sexual and reproductive health is significant and will affect many individuals, particularly those living in low and middle income countries. Now, this is certainly an interesting perspective, and it may suggest that there may be relationships to countries that have economic and healthcare disparities, although I believe that this is something that all countries will deal with, and this is a global problem, not necessarily only countries that have disparities. And this condition, in terms of impact, has resulted in social isolation with impact on sexual health. And this can mimic some other conditions that we are all familiar with. There are conditions of sexual orientation and gender identity that has led to isolation of subjects. Cancer has had a similar impact for those who had cancers that have definitely impacted their sexual function, has led to isolation in this regard. Disabilities of individuals, and finally, contagious disease such as COVID-19. The impact can be felt in different ways. It can have impact on health risk behaviors, whereby isolation leads to less good health conditions in terms of behavioral factors leading to adversity of health, obesity, tobacco use. In terms of sexual function, there has been anecdotal reports of its impact on one's overall ability to perform sexually. And there have been some reports that some men have had decreased arousal function, which could be related to the illness itself. And this has possibly a relationship to hormones, although this has yet to be fully worked out. But being a condition causing illness, you can see how this can affect one's sexual function. And indeed, psychological and psychosocial distress can develop, and Dr. Mona Rita will speak to this, I am sure. So what are suggestions for reducing a possible risk for transmission? The world of HIV has set aside various basic guidelines and recommendations, which include safe sexual practices, which is to use a condom, to avoid human-human contact, so abstaining from sex has been a recommendation. There have been interventions that have been recommended, such as circumcision, and this has certainly been done in many countries, including Africa, where HIV rates have been reduced with the implementation of widespread circumcision. Also, recommendations have been put forward for prevention, and this largely comes about through mass public education about the risk for transmission, the risk for the prevention of HIV transmission by safe sexual practices, and so forth. Now, it is important here to understand what we think right now about the risk of coronavirus transmission sexually. I put together this slide just a week ago, although it's been modified a bit. Earlier, Patry had made the suggestion for abstinence, as suggested for HIV transmission, because of concerns or accounts, anecdotal reports of transmission by oral anal contact or anal sex. And there have been reports of SARS-CoV-2 in saliva and feces, And there was a report that came out on the JAMA network online just yesterday that reported that semen can carry the SARS-CoV-2 virus as well. So there is some support for this understanding of that potential risk. It is understood that glandular cells of oral mucosa and rectal epithelia express a receptor, the angiotensin converting enzyme 2, by which the SARS virus can bind and enter cells. So therefore, it does have the risk, particularly in the anal tract. At this point in time, it is suggested that there may be some positive findings of the virus, including semen, and at this point in time, concern should arise because of this, although it is not clear that there is true transmission, even though there are findings in semen. And a suggested practice is to consider sexual protection measures at this time still with condom use, and discourage unprotected non-classical sexual behaviors or high-risk behaviors whereby transmission may still occur. Now, from a public health standpoint, we should recognize that there are some potential ways to go about controlling the health risk of COVID-2, and I list these here: from improved public health systems, improving surveillance mechanisms, various kinds of levels of governmental agencies and healthcare delivery organizations that can develop strategies for disease mitigation and control with advancing various medical interventions. And this has been a general concept for any kind of pandemic and widespread infectious disease. Certainly these kinds of concepts have applied to HIV, and these kinds of approaches have been used from universal provision of treatments, widespread testing, and various kinds of preventative therapies and antiretroviral treatments that have been brought forward for HIV treatment. And then from additional public health basic strategies, they can range from behavioral to social to structural, all surrounding various approaches that could be used to control HIV spread. And at this point in time, they could be considered for managing COVID-19 or coronavirus 2, although these sorts of recommendations remain to be well developed. In terms of health practitioners, for those who have social isolation, I think these are strategies that I would offer can be basically approaches that we can consider as healthcare providers in sexual medicine and andrology. Continue to provide culturally sensitive care, reduce any biases that we have with regard to those who are affected by the disease. We should be very objective and supportive of all patients. We should address this condition in terms of any kind of sexual dysfunction as we would approach any kind of survivorship efforts, with all available treatments and services being brought to patients, and then continue to provide basic sexual health education and promote healthy behaviors. And sexual health behaviors include lifestyle interventions, which have been widely promoted in sexual medicine. Even in this era of social isolation and perhaps unhealthy habits, we should try to limit unhealthy habits, and we should try to promote healthy habits. So restrain tobacco use, alcohol, drug abuse and use, poor nutrition, or sedentary behavior are unhealthy habits that should be controlled, and we should promote nutritious diet, exercise and activity, good physical rest, and positive social relationships. And all of this is supported by good scientific evidence of how our health can be improved. So by way of summary, the COVID-19 pandemic is a worldwide public health crisis with a recognizable impact on sexual health. And I think I've demonstrated that in my presentation, that it can have impact in terms of one's sexual function, both in terms of basic function as well as relationships that Dr. Rita will speak to momentarily. The sexual health impact of COVID-19 can affect all levels of sexual health behaviors, relationships, and has impact on how we can proceed as healthcare practitioners. The management of this sexual health adversity consists of thoughtful practices and education, as well as society and government programmatic efforts. So I will stop there, and I do appreciate all attention to that presentation. Thank you.
Thank you, Professor Burnett. Dr. Talal Murdad now. He's president of the Middle East Society is a consultant urologist and urologist and the president of the Middle East Society of Sexual Medicine. Father Dr. Talal.
Thank you. So hello everybody and welcome to our sexual health challenges during lockdown, COVID-19 pandemic, combined sexual health webinar. It's our honor and pleasure to have our speakers with us, Professor Burnett and Professor Munarida, Dr. Abdullah Al-Asami. As you know, this webinar is being organized and orchestrated by our dear colleague, Professor Saleh bin Saleh, the president of Saudi Society of Men's Health, and we extend our thanks and gratitude to him. As you all know, Middle East Society of Sexual Medicine is a sub-society from the International Society, ISSM. There are 6 societies in the world under the pattern of ISSM. One of them is the Middle East. And we work together with our executive committee and our scientific communication public awareness committee in bringing this webinar to you. So thanks as well to our sponsor, Tabuk Pharma. And I would like to introduce now our dear colleague, Professor Munarida. She is a professor of psychiatry at Ain Shams University, 20 years experience in the field of mental health service. She is one of the top-notch psychiatrists in the Middle East. She supervised and conducted and published several scientific papers, have tremendous experience in the field of evaluating and managing relationships and communication problems. She is a member of many societies, International Society of Sexual Medicine, Middle East. She is the chairman of the Public Awareness Committee, as well as of the ASSM, and she is the founder and board member of Egyptian Society of Sexual Medicine and Surgeries. Professor Mona, the floor is yours. And Professor Mona presentation, COVID-19 implications on marital and sexual life psychological aspect. Please.
Thank you, Dr. Talal. Thank you, my dear colleagues. It's my pleasure to join you with this presentation that is going to take about 15 to 20 minutes, where I'm going to talk about the COVID-19 impact on marital and sexual life from a broad spectrum. I will come across what is an epidemic, a pandemic, and how pandemic affects us. I will also highlight on how it affects us in mental health and sexual function during a pandemic. And we have to look at the current challenges we're facing now as sexual health service providers and the future perspectives. I need to hide this. Just a second. I need to hide this so I can see my old slides. Okay, sorry for that. How a pandemic affects us. Pandemics, as you all know, are a large-scale epidemic affecting millions of people across multiple countries, sometimes spreading throughout the globe. Pandemics are usually viral in nature, typically arising from an animal influenza virus that spreads to human. It's always difficult to predict when an influenza pandemic will occur. Pandemics are frequently marked by uncertainty, confusion, and a sense of urgency. And these 3 factors are very important in the mental health state of our patients, of all the individuals and humans, and secondary affecting their sexual function. Uncertainty may even persist when well into the pandemic, especially concerning the question of whether a pandemic is truly over or not. Pandemics can come in waves, as we all know. So the uncertainty, confusion, and sense of urgency may persist for a longer time. Pandemics are associated with a score of other psychosocial stressors, including threats related to health, to oneself and loved ones. There may be a severe disruption in our routines, separation from family and friends by social isolation, shortage of food and medicine, wage loss, social isolation due to quarantine or other social distancing programs, and school closure. All these are changes in our daily routines. Families may become malnourished if no one in the house is well enough to shop or cook, especially with elderlies. Personal financial hardships can occur if a family's primary wage earner is unable to work because of illness. These are all considered stresses encountered by the humans during a pandemic. Most peoples are resilient to stress, and many survivors of highly stressful events will likely emerge psychologically unaffected. However, during a pandemic, many people will become fearful, some intensely fearful. That is, the psychological effect of a pandemic will likely be more pronounced, more widespread, and longer lasting than a purely somatic effect of infection. That's why it is said that psychological footprint will likely be larger than the medical footprint. And mental health during a pandemic, negative mental health effects due to social isolation may be particularly pronounced among elder people and householders with adolescents, as these groups are already at risk of depression and suicide. What we see is a mass panic in societies with increased apprehension and confusion regarding the data of pandemic, especially in societies where the trust with the official numbers is missed. Emotional distress reaction can be diverse, ranging from fear, taking all the precautions excessively, spending all the day doing the routines of cleaning and disinfecting, to an indifference to fatalism, where they deny the occurrence of the pandemic or they try to rationalize it in a way that makes them feel better. So they just go on with their life as usual, not putting in consideration that they are putting themselves in risk of infection. Behavioral reactions to fear can persist even after a pandemic is announced to be cleared. Behavioral reactions to fear can persist. Mental disorders can be triggered to exacerbation, especially patients with already the diagnosis of anxiety mood disorders, and in anxiety disorders, especially the post-traumatic stress disorder. And the special population here are those who are either infected by the virus or living with someone infected, or those who have lost a dear one for COVID-19. Substance abuse increase the risk of substance abuse, especially alcohol and illicit drugs. And suicide may increase with social isolation, as it's been proved by previous pandemics, and literature mentioned that. Healthcare workers, we should be paying good attention for mental health, for the healthcare workers, mental health outcome and associated factors among healthcare workers treating patients exposed to COVID-19 in China, reported experiencing psychological burden, especially nurses, women, and those in Wuhan, as it's been published in JAMA last March. People may indulge in all kinds of superstitious behavior, hoping to keep them safe. And we also have the sickness behavior syndrome. There's a class of psychological reactions that are the direct physiological consequences of infection. People infected by viral or bacterial agents may experience symptoms including nausea, fatigue, sleep disturbance, depression, irritability, and mild cognitive impairment related to memory and attention. Sickness behavior is triggered by a pro-inflammatory cytokines such as tumor necrosis factors, interleukin 6, interleukin 1, 2. Immune reaction can involve neuroinflammatory, which may lead to sickness behavior. After mentioning all this mental state, what is the psychological, the impact on sexual function? As we can see here on the left side, it has been noticed that there is an increased online shopping for sex toys, dating, sexting, condom use, and natural sex boosting agents. In the presence of the stress, which is the too much togetherness, which is becoming a problem to some of the couples who had already suffered from marital problems, or those who lost loved ones, those who are fearing infection, fighting the blues, or fearing the economic stress. The stress performance bell-shaped curve can be seen that the more we have a stress, it's supposed that our performance will improve. But with prolonged and continuous uncertainty, the performance might shift to the right side, where I put an R, where the performance will start to decrease. How can we keep the individuals on the left side of the curve and not the right side? Is by their ability for using their coping mechanisms for the stress. And that's what we can see in our patients now. With the high level of stress enduring on individuals, we see that we have three categories, main categories of our patients. Those who are dissatisfied couples, who have problems, marital problems, and they have been in the lockdown. They started to have negative behaviors together, and marital problems became extremely high. Extreme reactions and potential marital conflicts, exacerbation of risk of domestic violence. As for partners who already exist a social dysfunction and they're suffering from a kind of social dysfunction, there is a higher risk for them to be exposed to more sexual dysfunction, as erectile dysfunction, premature ejaculation, anorgasmia, or sexual pain. As regard the desire, the change in appetite for sex, those who are their coping mechanism to use sex as relaxation or as a way to vent their stress, they will show increased risk for increased frequency for sexual behavior. But those who are using or considering sex, showing decreased appetite in sex during stress in general, will suffer from a hypoactive sexual desire disorder. A third category that are in need for urgent service, which are those who have been subjected to sexual violence by partners, domestic violence. And it has been recorded by the WHO that a report mentioned that the COVID-19 and violence against women, especially those who has been already subjected to violence, now being locked down, being too much with their husbands, will put them in higher risk for sexual and violence from the husband, with the inability to reach for help. So the current situation we're having now is the frequently asked questions from our patients, from the society. Is COVID-19 sexually transmitted? It has been said that it's not sexually transmitted, and I believe it's still now, because we're still seeing the mutation of the virus. We don't know, and it's still now, it's not sexually transmitted, but caution should be taken. Is kissing not allowed? Some people ask about this. And can I have sex with my partner? It's a very common question. The social isolation means no sex. My partner has COVID-19 with minimal symptoms. Can we still have sex? My partner has just recovered from COVID-19. When can we resume sex? Our lockdown reveals sexual dysfunction. How can we get help? These are the current situation. This is the current questions that patients are asking or posting on social media. We as physicians have challenges. The patients who are seeking help to hospitals and clinics are not allowed because of the lockdown. They fear risk of infection. So there might be need for help, but they can't reach for it. Patient in need for investigations and surgeries, we have to consider when and which patient we are going to operate on, and is this necessary to be done now or not. We have the economic constraints facing clients in the future, in the near future actually, especially in countries where the medical service is not fully covered by insurance. We have to, one of the challenges we face is the virtual care, the online service, with communities who are not really used to this kind of service. They prefer to visit the doctor in the office. So now they have to shift to an online. Some do feel it's okay. Some are not aware of it. Some are unable to use it. Some are worried about the security of online consultation, especially when it comes to sexual complaint. I think in the very near future, we have to study the impact of COVID-19 on sexual function. Probably by next year, we can see the publications, and we'll have more clear picture, more evidence-based about the impact of COVID-19 on sexual function, effect of the lockdown benefits on mental and sexual health. Did it really affect us positively or negatively? Guidelines for safe sex during pandemics, the precautions that should be taken. Yes, we do have suggestions taken from other previous pandemics, but still we need to know more about the COVID-19. Prioritization of service providing in case of pandemics and lockdowns. We need to have this in guidelines. Online and telesessions and virtual care guidelines need to be also revisited. And with that, I thank you for your time.
Yeah, thank you very much, Dr. Mona. Very conclusive presentation. And shall we go to our case presentations? Yes. Next is our colleague, Dr. Abdullah Al-Asani. He's a consultant urologist and urologist, and sexual medicine. He's the first Saudi sexologist being licensed, and he's the president-elect of MSSM, the Middle East Society of Sexual Medicine. He's a member of Saudi Society of Men's Health and member of Saudi Women's Health Group. There's 2 cases for interaction. Dr. Abdullah Assemi, the floor is yours.
Thank you, Dr. Talal, for this lovely introduction, and thank you all to have me with you. I will present actually 2 cases which I believe that it's related to our subject today. The first, I will start with the first presentation, which is this is a case that presented to me with 2 couples newly married, I think 2 months ago, or 3 months, family arranged marriage, seeking medical advice for inability to achieve complete sexual intercourse. Both couples were sexually inactive before the marriage. Both of them were virgin, and the first 2 attempts was successful, followed by several failed intercourses, even with the use of BDE5 inhibitors. The husband is 25 years old, medically free, morning erection present, good erection with masturbation before. Physical examination was unremarkable, labs within normal range, benign Doppler was normal, history of taking BDE5 inhibitors after the second failed attempt, and it didn't work. The wife, she's 24 years old, medically free, seen by our colleague gynecologist. Labs and ultrasound was done for her with no abnormalities. Her reports was excluding all organic reasons that prevent a complete vaginal intercourse. Back to you, Dr. Talal.
Yeah, okay. So they present your clinic with this complaint. I think
Yes.
both of them are brave to subject their sexual life. They need help.
Yes.
So the next step, where we go? As you know, for us as a urologist and urologist, either it's organic, psychogenic, behavioral, or something else. So those couples that are not organic, psychogenic, maybe Dr. Mana will have her input. And if behavioral, I don't know if I applied to them from their sex education, from sex attitude, why they have the first 2 attempts very good, and then it's failed. Although they are locked down in one house together now for 2 months. So they should work it out, unless there's something behavioral hidden behind us. So I may ask my colleague, Dr. Mana, to just elaborate about psychogenic or performance and anxiety for those couples.
When we usually see these couples, and we call this problem unconsummated marriage. Even if they had sex for a couple of times, but then they failed to continue, then it's an unconsummated marriage. We have to examine both of them, where we run a good psychological history taking, including puberty, including their cognitive ability to understand what's sex, their sexual beliefs. We have to investigate their sexual beliefs. We do personality assessment. We do a lot of psychometric assessment that is related to sexual dysfunction. Same goes for both. And we don't work without consulting with an andrologist and a gynecologist to exclude any organic cause for this unconsummated marriage. Once it is cleared, we psychiatrists and psychologists, we work on a plan where we use combined cognitive and behavioral. The cognitive part is related to their sexual beliefs, distorted beliefs, and correct them. And we also, in history, we try to take if there's we check if there's a history of sexual trauma, because usually we see that there is a sexual trauma happened somewhere in their previous life, not the previous life, in their past history. And we actually deal with the trauma by psychotherapy, and we add to that the use of vaginal dilators, plastic vaginal dilators, guided by the physician. The patient may use the dilators and to introduce the dilators to be able to overcome the pain. With the dilators, we put her for physiotherapy to help the pelvic floor muscles to relax. One of the major factors that we see here on a psychodynamic way is that there's sometimes fear of control. There is a control issue here. She's afraid to give the control to the husband, so that's why she might be tightening her vagina. That's if it's a vaginismus. But what if she has no vaginismus and the male has an issue with the vagina, with the erection inside the vagina? And I have seen many cases where they have good morning erection. They have a good erection if they are watching pornography. But when it comes to the wife, during foreplay, there is a good erection, but he loses the erection once there is an intrusion. And that's because there is a conflict somewhere that needs a lot of psychodynamic work. What is the fear from the vagina? One of the very, very obvious reasons would be an intimidating wife in personality, in social standards, in education. She isn't intimidating to him in a way or another, so that's why he cannot penetrate her. So men are more difficult to understand and to come to the real cause of their failed erection just before getting intrusion. They're more difficult than women, tell you the truth, from my personal experience.
Sure, thank you very much. So, Professor Bernard, you heard the history of the cases. What stopped me really here, he's a young chap. He's not diabetic, not hypertensive, no organic disease. And I see one of the investigations is to do penile Doppler exam. I think it's little bit, I'm not talking about guidelines, but normally young chaps, we don't do penile Doppler. We can give them Viagra, stimulate them, you know, to do it, but not penile Doppler. What's your comment on that?
Yes, well, yeah, certainly this is a very nice case presented by Dr. Al-Assimi, and I'm sure this sort of clinical presentation we do see often enough. To get to your question, Dr. Mehrdad, I agree. We typically don't, at least in our practices in the United States, initially do a lot of the more invasive workups. The ultrasound that also involves penile injections and evaluating for erection responses. Many times we will do trials of the non-surgical therapies, such as the oral therapy, without necessarily doing that. But again, I think there's no harm in doing that kind of workup. It did establish that there's nothing physically wrong here. And so that's an acceptable approach. I think what is interesting about this case is that the patient was evaluated this thoroughly and also already started with a PD-5 inhibitor, maybe just for initial sexual encounters. And it makes me just wonder again for this couple, as Dr. Veda has just discussed, there may be a very challenging dynamic here with a new couple, maybe not even understanding what sexual activity is all about. And there may be a lot of issues there, and maybe there's expectations about how a certain performance should occur. So her role in this is absolutely valuable. And we see this with some of our couples in the United States as well, where the dynamic has all of these potential factors involved with perhaps wild expectations about performance. And so that kind of discussion, I think, is appropriate. As far as the PD-5 inhibitor, it's interesting, he responded twice, but then stopped. And then there are discussions about how to optimize responses to PD-5 inhibitors. Is he taking it correctly? Is he taking it appropriately in terms of timing with sexual encounter, when it would have its effect based on pharmacology in the body and other kinds of other enhancing factors that ensure its best benefit? So yes, a lot of discussion, I think, surrounding this case, although I think it does have more in the lines of the psychogenic side of it more than likely.
Sure. Okay, Dr. Saimi. So you have those couples coming back to you soon, or?
Yeah, I'm following them. Actually, this couple, I noticed I was taking a detailed sexual history for them. Both of them, they know the sexuality or the intercourse, but the problem is with because they are new and they face a new lockdown, and the husband is more stressed than I'm with Professor Mona. Yes, he's more stressed about what is the what's the impact for manhood in front of his wife. This is the stress that I noticed a lot. And the female, you know, our culture is the culture impact on our female. They are just they are shy and they are not open, and she's only concerned about what's the next step. But for him, it's what's the next step and what's the future. Do I have to use the BDA5 for all my life? Actually, the first attempt, Professor Burnett, he was succeeded without any help, but he used the BDA5, and then he came and he said, I use it, but I didn't have any. Just explain for him that it's sometimes it's need longer time. Sometimes you have to understand, you have to be understandable. This issue have to be resolved with the time. So yeah, I'm trying to work out to
Sure.
think the issue between them. This is the most important. If they are supporting each other, I have seen a lot of cases that with the understanding and open with each other, it's better than what we give them. This is the most important thing.
Sure. So, Dr. Qutaiba, have more comments, or we can move to the next case?
No, it's interesting because these problems happen even before the lockdown. We see these cases all the time. I mean, it is just exacerbated and more complicated with the lockdown. But we see them all, and I'm sure Professor Amina will agree. We see them all the time. But I think it's just made worse with the lockdown.
Yeah,
I agree.
Yeah, that's the truth.
Okay. Interesting.
I
So,
just got.
I just need to add one thing to Dr. Qutaiba. You know, the lockdown, some couples, especially the newly married, are expecting themselves to be very much sexually active, since they are newlyweds and they have a prolonged honeymoon, if we can call it that, and they are simply expecting. So their expectation is very high, and this itself adds to the burden of an anxiety that will affect their performance negatively.
I agree. We argued about this with Professor Saleh a couple of months ago when the lockdown started, and my expectation, I said, it's going to be negative. And some of our colleagues said, well, there's going to be free. It's free time. There's no work. They're getting paid, and it should be a free sexual activity. But it's not what's happening.
Well, let me add here one. This is a male point of view, but for women who are taking care of the kids and studying online and having to deal with the kids all day long, this is their daily activities that they have to go to school or outside. Now the burden on the women is more, so they are not really in their usual routine. That's what I meant when I said the daily routine has changed, and it doesn't mean it will change for their best interest, but might affect one of them negatively.
Professor Saleh, you were going to say comment?
Yeah, I just want to ask Professor Burnett one question.
Yeah.
Now, is it routinely to do a penile Doppler for any cases going for penile prosthesis? Is it a must or optional?
right. So that does make the point there that when you're considering something that's irreversible and invasive, such as a penile prosthesis surgery, there may be a greater indication to do that than for some of the other therapies that we have now available that are not irreversible or invasive. So penile prosthesis surgery, in the majority of cases, I think would be valuable to do it to help justify doing the surgery. Insurance companies many times in the United States need to see this. In addition, it may help reassure the patient of the severity of the erectile dysfunction. Is it required every time? Absolutely not. Certainly patients can be counseled and understand all of their options and proceed ahead, understanding that they may have a severe enough form of erectile dysfunction or just have a desire that they want a penile prosthesis, and you can still proceed as long as all that documentation, counseling and documentation has been done and thoroughly put into the medical records that's been so. So it's not required, no, but I think it can be very helpful, particularly for invasive procedures.
I think we have to proceed for the last case of Dr. Abdullah, otherwise we're going to run out of time.
Yeah, okay. So this is my next case. I think this is we will see it a lot after.
Dr. Abdullah, can we make in a shorter because
Yeah. Okay. I'm sorry. Yes. Did you see my? Yeah. This is a case 2. 58 years old male with history of diabetes and benign prostatic hyperplasia on BDA5 inhibitor for ED since 1 year, and the patient was satisfied. His wife is not aware of his condition as he's taking his medication or the BDA5 behind her back or secretly. After the lockdown, his supply was finished and waited for 3 weeks due to he's afraid of catching the corona if he goes outside. When he finally bought, his response was lower than what he expects or what disease usually have. It was diminished to the same dose and the same brand. He tried the maximum dose from the same brands that he used, and even he tried another molecules from or another brands, but it didn't not work also. This is my second case.
I think Professor Amana will be in a good position to comment on this. This guy was responding very well until he ran out of prescription. So obviously there's a strong psychological factor.
Exactly. He's on the right side of the bell-shaped curve I show you, because simply his anxiety is overcoming. And the problem is that if we give an anxiolytic, it might affect his sexual performance. So sometimes we have to ask the patients to do some cognitive exercise to minimize the anxiety, to meditate, to do some sports, to just try to delay the intake of any kind of anxiolytic. And if we have to, then we do prescribe one of the 2 most safe anxiolytic antidepressant drugs for sexual dysfunction. One of them is a dopamine reuptake inhibitor. So actually, yes, this is an anxiety performance that is affected in an already diagnosed patient on medication.
Not serotonin, dopamine, you said, not SSRI.
Yeah. Yes. Bupropion is considered a very good antidepressant and has the least side effects regarding sexual side effects.
Excellent. Excellent.
Can I make a point?
Yes,
I'll be quick about it, but then this is a nice case here of a patient who probably has organic and psychogenic factors behind his erectile dysfunction, and he has been using a PD5 inhibitor. Professor Mona has done a great explanation of some pharmacology, but I certainly would counsel the patient, help him understand that yes, he could still do his very best to preserve his best sexual health by optimizing his lifestyle and keeping his diabetes under control, and thinking about continuing to do some of the lifestyle variables that I spoke about. And so this, to me, has a multi-pronged approach. Counseling, proper expectations, medications, lifestyle, all of these factors should come into play.
Can I just, Dr. Abdullah, you've finished your case?
Yeah, it's finished.
Okay. Can I ask Dr. Burnett? We have a couple of questions. Now we know from Professor Muna's presentation, which probably has been changed since she done the slides, because now COVID-19 might be sexually transmitted. We know that now, don't we? Yes.
Well, yes. Well, we just, as I mentioned, the Journal of the American Medical Association Network online, JAMA, just published an article yesterday, literally 24 hours ago, that suggests that there are findings now of the COVID in semen. My slide that I made up a few days ago, I said there's no evidence for it because that was the data then. That's changed now just within the last day. But the point is here that we do not know yet whether it truly is transmitted with sexual activity during that sort of from the semen, even though it's been found there. Conceivably, there is that risk. And I did also make the remark here that the epithelium and mucosa in the rectal area is thought to be a high susceptibility area for how the transmission should occur. So be aware of that. So the recommendations right now are safe sex, condom use. We don't have all the answers yet, although there is some suggestion there may be a risk.
And we know now also 70% of the patients with strong symptomatic cases, 70% have them in the feces also. So I think it's obvious. But since it's upper respiratory, so it's definitely present in the saliva. So I think we can consider it like HIV. It's present in body fluids. So I think we should take same precautions as the HIV.
Good point.
Yes. Okay. My other question to you about this new trend in New York of giving nitrous oxide to doctors for a few minutes just to give them some sort of a protection. So if nitrous oxide is useful as a prophylaxis, do you think PDE5 inhibitor has any role here to protect health workers or patients generally? Does it play a role in prophylaxis, PDE5 inhibitor, as a releaser of nitrous oxide?
Yes, just to be brief, there has been evidence that use of PDE5 inhibitors has been beneficial for lung conditions, pulmonary hypertension, people in high altitude conditions. So there may be some benefit there. I think it's a good hypothesis. Is there any good studies just yet? We don't know, but possibly it could have a role. We're thinking about all kinds of things, and I would still support that.
It might be a protective for the lungs. My other question is, why men are dying more than women? Is there a gender, a hormonal factor? Is the testosterone playing a factor here? Is the estrogen protective? Why men are more than men, and why men are more? There's more mortality. Is there any explanation for this?
Yes, as far as that's concerned, that's an interesting observation, and I don't think I have an easy answer for you with that at this point. I think that both genders are affected. We know that, and those with prior comorbid health conditions are at greater risk. But as far as testosterone being a major risk factor, I don't think that there's good evidence to help us understand.
Or it could be the other way around. Estrogen is a protective factor. My other question to you, Professor Burnett, is since it is present in the semen, and measles virus is also present in the semen, and measles damages the testis, do you think this will cause damage, a fertility problem? Do you think there is a prospect for a damage like a measles virus? I mean mumps, like a mumps virus?
Yes. Well, again, I think it's a great hypothesis, and again, all of these are considerations that we just don't have the scientific answers just yet. I think we have preliminary data that give us some concern, and so we'll have to wait and see in terms of whether there's some real effect there. But I think you raise a great point, and so that remains to be well studied and informed to follow.
Sure. Thanks.
Good thought. Very good thought.
Just have one more comment by Dr. Qutaiba about the low testosterone is a promoter of COVID-19 infection. If there's any studies, because I've seen in one of the metabolism journal that testosterone is a key hormone in the context of COVID-19 pandemic.
Yeah.
Whenever testosterone is low, that's more indication for infection of COVID-19.
Yes. Well, I mean, I think that these are, again, hypotheses. I mean, we just heard that men supposedly are higher risk, and you would consider they have higher testosterone levels. But as I mentioned in my presentation, there have been some anecdotal reports of some men feeling that their sexual arousal has been affected by having the disease. And I think the relationship there probably is an illness, although we do typically think of chronic illnesses or just very severe illnesses impacting the sexual function, and therefore is it mediated by a low testosterone effect. Again, this remains to be really well studied. I think this is an interesting hypothesis, but it's just there's no definitive data as of yet, at least by my review.
Sure. One question to Professor Muna. Now we can conclude that the lockdown has generally a negative effect. It's not a positive effect. Generally, most of the factors are on the downside, not on the upside, regardless of whether the people are working or not working. They're being locked down together in the same place. It's generally a negative effect. I think you'll agree on that.
I will agree to an extent, but to say that it's a conclusion, we need to wait till next year to see the impact of the lockdown on the psychological status and marital status, marital condition, problems, conflicts. Has there been an increase in them? Has there been an increase in sexual complaints secondary to the lockdown or not? But we can't make a conclusion. But we do see people who are in the lockdown and they are enjoying their time. They're doing fine because they have a good coping strategies. There are so many young generation doing so new innovative things through the digital media, and they are doing fine. But those who are with very low coping mechanisms are definitely going to be suffering a lot. Those with pre-existing marital problems, sexual problems, it's going to be exacerbated.
Sure. For all the speakers, I have one question here. The COVID-19 started on March 11, 2020, the outbreak. The question is, what implications for sexual health? Is it globally or individual countries?
Yes, I could certainly speak to that. I think it is a global phenomenon. I did put one slide up where at least there was one investigator who suggested that the impact is greater in the countries of low socioeconomic status, and that may reflect economic disparities, healthcare disparities, and maybe not having the resources of Professor Mona and the rest of us in some countries, and therefore patients are more disproportionately affected because of lack of services and proper education. So I can understand that potential risk, but I don't think that purely as a matter of a lower economic country having a higher risk. We're all humans, and I think all humans can be affected by this condition, irrespective of the country.
If I may add to that, in the future guidelines, definitely it will be for global, but it will need to be customized according to the culture of every region, because in every guidelines, sometimes some of those guideline bullets are not suitable for certain cultures. For instance, what recently has been published by New York City Health something, I can't recall it right now, is that the safest sex during pandemic is self-sex, which is sometimes a questionable, doubtful, not very well accepted in so many cultures. So I do believe any guidelines will need to be revisited and customized according to the acceptance of the cultures.
Good point. Very good point.
Totally agree.
Can I just have a comment, please?
Sure.
Sure.
Professor Saleh.
Professor Saleh.
It is actually just one comment about the question of why men are affected with COVID-19 more than women, and even the mortality rate in men is higher than women. I do agree there is no clear study, and we have to wait for something coming in the future. But one of the theories, men they do smoke more than women, and people who are smokers, they are more vulnerable for complications. That's number one. Number two, you have this ACE receptor, which is present in the lung and the testicles, that also increase the vulnerability of the men to get more complication once they get hit with COVID-19. Lastly, men, they are more upfront and they go more out compared to women. So the risk for
Yes. They take always. Yes, I agree.
But the risk exposure maybe, at least in the United States, is high because certain occupations, particularly in the United States, we're seeing those of lower socioeconomic background having more human contact occupations, and they're a greater risk. And nursing care, which is predominantly women in the United States, at least they have high risk there. So I think it can depend upon the types of exposures. And you're right, it may be country dependent. It may depend upon different countries and what kind of occupations and activities may be present in different countries we'd have to look at.
Great. I have one question for Professor Mona. Now in Saudi, actually, we don't have a lot of psychologists or psychosexual counselors. Dr. Abdullah Al-Asami is one of the few people who can do this. So I guess it is a legacy. It's to have somebody who can cooperate with you. But for the remaining of us, the neurologists, who might be faced with the case, the second case, for instance, what would you recommend for them if they don't have the facility to refer the patient to a psychotherapist?
The second case, the one who on medication who has a problem, although increasing the dose?
Yes.
Yeah.
Or even the first one, if you need a psychotherapist and you didn't have one handy nearby. What shall we do as an andrologist?
Well, we just mentioned that nowadays we need to overcome the physical being together, or what I'm trying to say is that now that we're promoting online consultation, there's always a way to consult with someone abroad. Look at this meeting. We are from different continents, so that you can always use a psychotherapist who is abroad. But if you want to give an advice, then you have to help the patient to use relaxation techniques to unease his tension, and because one of the major things that this patient, I may say, he's about his wife finding out his condition. This is a major thing. He's hiding the whole story from her. So we have to understand why he is afraid that she finds out about his illness or his intake of drugs. This fear is controlling him to the extent that his performance is affected. So we need to know why the worries are increasing in his head. If he has stresses from outside, then we need to deal with the stress. You can advise him by staying in a healthy style of life. You can advise him to do relaxation techniques, to do meditation, to have a healthy discussion with the wife, healthy talks, and to maybe easing up the frequency of sexual intercourse together. But as I cannot be an andrologist, it's not easy for an andrologist to do the psychotherapist work, because it takes a lot of experience to become an andrologist. So same goes for the psychotherapist.
Even for us as andrologists, I mean, our questionnaire to the patient to tell that this is psychogenic and not organic, our questionnaire is really limited. And our scope of questioning the patient to get out some psychogenic aspect is limited. I understand from the workshop I attended, you did in Cairo a few months ago. I think you dig in the history for the patient from the minute he's born, not even from adulthood, which is really important to get the whole idea about his psychological aspect of impotence.
In Dr. Abdullah, first I mentioned that we have to search for, we have to ask about a sexual trauma. And sexual trauma used to be, we used to understand sexual trauma as an abuse or a rape. No, sexual trauma can be just exposure to unsuitable material to the age, or hearing something while in adulthood. So trauma is not just being exposed physically, sexually to a rape or a molestation. It could be a cognitive trauma.
Okay.
Totally.
So, Dr. Qutaiba, I think I will make one consensus of this combined sexual health webinar, that we do not know exactly how the threat of this current pandemic will play out in terms of downstream implications on sexual health. This could be one of our consensus home take message from this meeting.
I agree, and there is, yes, go ahead.
So I would agree that we think it does have impact, and I think we're defining various areas in which it has that, certainly from a psychosocial perspective, from a physical perspective, and I also touched on how we can manage the patients as practitioners. Mona had some great ideas and recommendations, and I certainly think that even from a healthcare agency and government perspective, we need to address this as a condition, as much as we are dealing with HIV and maybe some other pandemics, that sexual health is still a very important aspect of the well-being of our patients. And I hope that our agencies and our governments recognize the seriousness of that of sexual health as much as physical health in terms of the impact of the pandemic.
Sure. I just want to say that this is the most rapidly spreading disease we have ever seen, worse than the Ebola, worse than the others. Also, it's not like HIV, where we have a long time to research and we have to work fast. For the psychological, for the biological effect of this disease is not going to leave us. It's not going to leave us alone. it will get worse. So we need to work fast. Like we're looking for medication for the HIV, for the for the COVID-19, we need to research the psychological and the long-term biological consequences of this illness, and we should do it in months, not in years.
Well, let me tell you something finalized here. We are writing the book. So we are in chapter 2. We don't know what's going to come up in chapter 3. So we have to wait till the whole pandemic is over, do the research so that we can say why it's affected the men in mortality, why is it sexually transmitted or not. That's why we say this is what we know till now. And we are giving the guidelines according to the level of, according to the evidence base till today. That might be changed next week. And that's one of the uncertainties that even we as physicians are having.
Sure, I agree. So Professor Saleh, Dr. Mardad.
Yeah, Professor Saleh, please. We lost his voice. Okay.
Okay, Dr. Talal, you can conclude.
Okay. So final question for Dr. Asemi, our sexologist. Sex can still be sexy in the time of COVID-19?
Yes, we can. Yes, actually, I give. This is the most. I'm talking about our background. I'm back. I always emphasize with my patient: just be open with your partner. Life will be easier. It will be sexier actually, even in lockdown. This is true. We can do it. We can, if we understand it. We can, if we share our fear and share our expectation with the partner. It will be sexier. This is we can succeed it if we want.
Great. Professor Saleh, you want to say something, and then there's no vote.
I do agree with everything that has been said, and I think what we know is much less than what we don't know, and I believe future will let us know how to deal with this in a much protective way. But till then, protect yourself and protect your partner.
Sure. So to conclude, thanks to Professor Muna and Professor Burnett, Dr. Talal Mardad, Professor Saleh, and Dr. Abdullah. Thanks everybody for very informative and very useful. And we hope that we'll meet again and maybe with more information, maybe in a couple of months with more information, more data to present. Thank you all.
Thank you.
Thank you.
Thank you.
Take care.
Be safe.
Bye.
Be safe.
Thank you. Be safe. Thank you.
Thank you.
Bye-bye.
Bye-bye.